welcome you all to PRAGNAVARIDHI lecture series conducted for first year BMS. As we know, there was already one session on GIT by Dr. Uma ma'am, and today ma'am will be continuing GIT. Handing over the session to you, ma'am.
Okay. So the next after the pharynx is the esophagus. So esophagus is a muscular tube about 25 centimeters in length. It will be always collapsed at rest, and whenever the bolus of the food is passing, it will dilate. It is flat in its upper two-third part and it is rounded in its lower one-third. It commences at the lower border of cricoid cartilage, that means at the level of cervical 6 vertebrae. This may be asked for MCQ. It descends along the front of the spine through the posterior mediastinum, passes through the diaphragm and entering the abdomen, terminates at the cardiac orifice of the stomach, opposite the 11th thoracic vertebrae. So the cardiac orifice will be present at the level of the 11th thoracic vertebrae. It is one of the MCQ question what you have to answer. So the total length of the esophagus is 25 centimeters. The length will change from birth. At birth, it will be 8 to 10 centimeters. End of first year of age, it will be 12 centimeters. And about fifth year, it will be 16 centimeters. And from 15th, it will be 19 centimeters. The diameter varies whether the bolus of the food or fluid passes through it or not. Based on the diameter, based on the bolus of the food, diameter varies. But at rest in adults, 20 mm but can stretch up to 30 mm in adult. At birth, it is 5 mm and at 5 years, it is 15 mm. This is needed to analyze the stricture through the esophagus. General direction of the esophagus in vertical. So how it is, what are the curvatures, what you can see related to the esophagus. There will be 2 or 3 slight curvatures, what you can see vertically. At its commencement, means at the pharyngoesophageal junction, slightly it is mediated in the median line. It inclines to the left side at the root of the neck, gradually passes to the midline again, and again deviate to the left as it pierces the diaphragm and passes down to open out into the cardiac orifice of the stomach. The esophagus also presents an anteroposterior flexor, anterior to posterior, based on the curvatures of the thoracic vertebrae and cervical vertebrae. It is the narrowest part of the alimentary canal, being most contracted at its commencement. And at the point where it passes through the diaphragm also, it is constricted. But flexors, cervical vertebrae is convex anteriorly, where it is reciprocal with the curvature of the cervical vertebrae. And as it passes in the thoracic cavity related to the posterior mediastinum, as the thoracic vertebrae are concave anteriorly, it follows the same curvature, concave anteriorly. In the neck, the esophagus is in relation with the in front with the trachea, and at the lower part of the neck where it projects to the left side with the thyroid gland and thoracic duct in front. Behind, it rests upon the vertebral column, and the muscle in the cervical region is longus colli muscle. On each side, it is related with common carotid artery, especially in the left side as it inclines to that side, and part of lateral lobe of thyroid gland and recurrent laryngeal nerves. In the thorax, it is at first situated a little to the left of the median line. It passes across the left side of the transverse part of the aortic arch and descends in the posterior mediastinum along the right side of the aorta until near the diaphragm, where it passes in front and little to the left of this vessel previous to entering the abdomen. Next is the coats of the esophagus. It is made up of 4 layers. From within outwards, it is a mucous membrane. Deep to it is a submucous. Deep to it is a muscular coat. Outermost is the fibrous coat from inside to outside. It is thin-walled organ measuring about 2 mm in wide. Unlike other areas of the gut, it does not have the distinct serosal coat, serosa, which forms the lining membrane, outer coat, but it is not there related to the esophagus. But it is covered by a thin layer of loose connective tissue, which forms the 4th coat, outermost coat of the esophagus. This is a picture of the esophagus. You can see it is constricted because of the circular muscle coat outside, and outside to that is the long-term muscle coat, and you can see the vascular architecture inside the submucous coat and the mucous coat protruding inside longitudinally. This is the related with applied aspect of the esophagus, congenital tracheoesophageal anomalies. So initial stage it will be the esophagus gives an tracheal bud, and in that bud, if the connection is still persisting, it is responsible for this kind of anomaly. So there will be two-way opening, esophageotracheal fistula, which is the commonest type. In newborn, it has violent vomiting and coughing will be there. And polyhydramnios is a condition where you can see this kind of thing. Partial obstruction of esophagus can also be seen in stricture, atresia, newborn salivate excessively, becomes cyanotic, and vomiting will be there because the food cannot pass into the stomach as there is a two-way opening. Partial opening means that it is not connected completely. Constriction of esophagus, beginning of esophagus. There will be one constriction that is called as pharyngoesophageal junction at about a 6 inches from the upper incisor teeth. At the level of arch of aorta, as the arch of aorta crosses the esophagus from right to left, directed upwards, backwards, and to the left lateral side. So it lies, the esophagus is compressed at this particular level as it is crossed by arch of aorta, and it is at the level of 9 inches from the incisor teeth. So just below that, at the level of left principal bronchus as it crosses anteriorly, at 11 inches from the upper incisor teeth, and the esophagus is also constricted as it pierces the diaphragm. It is 15 inches from the upper incisor teeth. This is, they are going to ask for 5 marks question, constrictions of esophagus. So this is the answer. Generally, what is esophagus, what is its extent, and what are the constrictors. This much is enough. If they write, they will get the marks. Esophagus is divided into functional sphincters. There are two sphincters, upper esophageal sphincter and lower esophageal sphincter. Upper is a 2 to 3 mm zone of elevated pressure between pharynx and esophagus, where you can see a sphincter there. It relates to cricopharyngeal muscle, what you can see anatomically. Lower esophageal sphincter is located at the junction between esophagus and stomach, usually localized at or just below the diaphragmatic hiatus. Despite distinct physiological function, it is not easily to distinguish anatomically. There is no thickening of sphincter here. The smooth ring of muscle fiber is not thickened. So anatomically, you cannot identify the sphincter, but physiologically, the sphincter action is present at the gastroesophageal junction. So there is an unusual blood supply to the esophagus because it is distributed in the cervical region and also in the thoracic region and the abdominal region. Half of it, half inch length of the esophagus as it pierces open out into the cardiac orifice, the stomach, and the blood supply is totally different. So cervical esophagus, right and left superior and inferior thyroid artery indirectly supplies into the esophagus. Thoracic esophagus up to tracheal bifurcation, right and left inferior thyroid artery, and directly there will be blood supply to the esophagus from the aorta as the tracheobronchial tree. It supplies both of them together. Then abdominal esophagus, branches of left gastric artery and branches of splenic artery posteriorly. Here the left gastric artery is a branch of common hepatic artery, left gastric artery, common hepatic artery. From there, the esophageal branch will supply into the esophagus, and the branches of splenic artery posteriorly, the small twigs may supply into the esophagus. Venous drainage, intraesophageal drainage, longitudinally arranged in submucosa, distal end portal anastomosis. Extraesophageal drainage into locally corresponds to the vein by the inferior thyroid vein, azygous and hemiazygous vein. So you can see the blue color veins passing and supplying throughout the length of the esophagus. You can see the distribution. And then in the stomach, in the region of the stomach, the fundus, you can see here the cardiac orifice of the stomach, the esophagus opening into the stomach. This is the fundus of the stomach, and this is the celiac trunk which is supplying into the esophagus. the abdominal part of esophagus, left gastric and splenic, draining the venous blood. Now supply parasympathetic is from the vagus, motor to the muscular cord and secretomotor to the glands, which secrete the exocrine secretion and lubricates the passage of the esophagus. Sympathetic from cervical and thoracic sympathetic chain. It helps in contraction of sphincter, relaxation of the wall, and helps in peristaltic movement. Intramural or intrinsic in the wall of the esophagus, combination of all innervations from the plexus and the ganglia. In muscular layer, it is called as myenteric plexus of Auerbach. In submucous, it is called as Meissner plexus. Next, going on to the anatomy of stomach. It's also called as gaster, meaning stomach is a muscular bag and is the widest and the most distensible part of digestive tube. It connects above to the lower end of esophagus, below to the duodenum, acts as reservoir of food, helps in minimal amount of digestion of carbohydrate, protein and fat. Location, anatomical position. This is also asked in the practical examination. It lies obliquely in the upper and left part of the abdomen. Upper and left part. Related to the 9 regions of the abdomen, it is occupies the epigastric region, umbilical region, and the left hypochondriac regions. It will not be there in the left lumbar region. So it is the 9 regions of the abdomen, and the stomach lies in the 3 regions here: epigastric, left hypochondriac, and then the umbilical region. Depending upon the degree of distension, when it is empty, the stomach is J-shaped, partially filled, it is piriform shaped, and it is when in obese person, it is horizontal. Length is 25 centimeters. All these are MCQ questions also, or the stomach will be asked for 10 marks question. GIT carries 16 marks, around 14 to 16 marks, and it will be asked for 10 marks question. If there is a 10 marks question, stomach will be asked. Length 25 centimeter, capacity at birth is 1 ounce, puberty 1000 ml, in adult 1000 to 1500 ml is the capacity. So at birth 1 ounce means 30 ml, 30 ml means 5 spoons, one spoon is equal to 5 ml. Okay. External features, stomach has 2 orifices, cardiac and pyloric orifice, 2 curvatures, lesser and greater curvature, 2 surfaces, anterior surface and posterior surfaces. Cardiac orifice joins the lower end of the esophagus, lies behind the 7th costal cartilage. Okay, 2.5 centimeter from junction with the sternum, laterally to the left side. At the level of T11 vertebrae, you can see this cardiac orifice. Pyloric orifice at the lower end of the stomach opens into duodenum. It's an empty stomach and in supine position, it lies 1.2 centimeters to the right of the median plane. In the median plane, you have to go 1.2 centimeters to the right side. Okay, there you can see the junction between the stomach and the duodenum. That's called as pyloric orifice. At the level of lower border of L1 vertebrae, or it lies at the level of transpyloric plane, guarded by pyloric sphincter. This is anatomically, you can see the sphincter. Always keep the lumen closed until and unless it is converted into the homogeneous paste by a mixture of food with the pepsin secreted by the cells in the stomach. Smoothing of muscle fibers which become thick and keeps the orifice closed. It is thick. So this is the pyloric orifice of the stomach, cardiac orifice of the stomach, the lesser curvature of the stomach, greater curvature of the stomach, fundal part of the stomach. And this is the point of incisura angularis. From there, the line which is drawn divide the pyloric part into pyloric canal and pyloric antrum. This is the body and this is the fundus, where it will be filled with the gas. Lesser curvature is concave and forms right border of the stomach, provides attachment to lesser omentum. Most dependent part of curvature in angular notch or incisura angularis. This is the most dependent part called as incisura angularis. MCQ question. Greater curvature, convex and forms left border of the stomach, provides attachment to greater omentum. Gastrosplenic and gastrophrenic ligament are also attached to it. At its upper end, it presents notch called cardiac notch, which separates the stomach from the esophagus, 5 centimeter longer than the lesser curvature. See, this is the notch here between the fundus and the left border of the esophagus. Two parts of stomach is subdivided into four parts. Insula angularis or angular nerve divides the stomach into two parts. Cardiac part made up of fundus and body. Pyloric part, pyloric antrum and pyloric canal. You can see the dotted lines there where you can bifurcate. These are the subdivisions of the stomach, what you can see. They may ask you about the subdivisions of the stomach. Or when you write the 10 marks question answer, you have to put a heading that subdivisions of the stomach, and you have to draw this figure and you have to indicate. Surfaces, anterior surface also called as anterior superior surface, faces forwards and upwards. Posterior surface, posterior inferior surface, faces backwards and downwards. Cardiac part of the stomach made up of fundus and the body. So fundus now, upper dome-shaped part situated above and imaginary horizontal line drawn at the level of cardiac are commonly distended with gas. Fundus. Body of stomach is a part of cardiac. Part of the stomach lies between fundus and pyloric antrum. Can distend enormously along the greater curvature. Gastric glands are distributed in fundus and body. Contain all secretory cells. Mucus secreting cells, digestive enzymes, zymogenic cells are there. Pyloric part, sulcus intermedius, a shallow groove on the greater curvature which separates pyloric antrum from the pyloric canal. Pyloric antrum is 7.5 centimeters in its length. Pyloric glands are rich in mucus secreting cells. Pyloric canal length is 2.5 centimeters long, narrow and tubular, terminates at the pylorus. So the pyloric part, pyloric antrum, relations, peritoneal relations. As it is covered by the peritoneum and suspended by the greater omentum and lesser omentum. It forms the serous sac lining the abdominal organ. Stomach is lined by the peritoneum on both its sides. At the lesser curvature, peritoneum extends and become continuous the lesser omentum. You can see here, this is the lesser omentum, the inverted L-shaped double-layered peritoneum here as it suspends along and passes along the lesser curvature. Here it is the greater omentum. Okay, it's called as the policeman of abdomen. At the greater curvature forms the greater omentum. At the fundus forms gastrosplenic ligament. You can see the gastrosplenic ligament. Gastrophrenic ligament means attaching the stomach into the diaphragm, attaching the stomach into the spleen, gastrosplenic. Here it is a greater omentum. It is a double fold layer of peritoneum made up of 4 layers. First layer, second layer, third layer, fourth layer. Visceral relations, viscera means organs. Anteriorly, liver. Okay, you can see the color change here. This area related with the liver, area related to diaphragm, area related with the anterior abdominal wall. Okay, and a part of it is related with the transverse colon and the anterior abdominal wall. Bed of the stomach. This is 5 marks question. 5 marks question. Posteriorly, the structures are related to the posterior surface of stomach and it forms the stomach bed. So, the structures which lie posterior to the stomach separated by the greater sac of peritoneum. Okay, there will be extension of peritoneal sac posterior to the stomach separating the structures from the posterior surface of stomach. And what are those structures? So, you can see here the list. If you write this much also, they will give about 4 marks. Diaphragm, left kidney, left suprarenal gland, pancreas, transverse mesocolon, splenic flexor of colon and splenic artery. Along with this, if you draw the figure, you will get the good marks. See, this is the figure. You have to draw this figure. Minimum 4 and of marks they will give along with that list of structures which lie in the bed of the stomach. You can see the dotted lines represent the superimposition of the stomach and the structures which lie posterior to the stomach. You can see here the pancreas, the splenic artery, left kidney, left suprarenal gland, spleen, diaphragm, a part of colon, okay, and then root of transverse mesocolon, okay. All these are the structures which lie posted to the stomach, and you have to draw this figure. If you want, you can take the screenshot. Blood supply, 5 branches will supply into stomach. Blood supply stomach is also 5 marks question separately. 5 marks question. So arterial supply, you have to write left gastric artery, right gastric artery, right gastroepiploic artery, left gastroepiploic artery, and short gastric artery. This much if you write also, they will get the marks. Or you can write branch also. Left gastric branch of celiac trunk, right gastric artery branch of common hepatic artery. Right gastroepiploic artery is a branch of gastroduodenal artery along greater curvature. Left gastroepiploic artery branch of splenic artery supply along greater curvature. Short gastric artery branches of splenic artery which supplies into the fundus. There it will be about 5 to 7 branches which supply. So take a screenshot. This much if you write with the figure, you will get 5 out of 5. See this figure. You can see here the abdominal aorta, the celiac trunk, the left gastric artery. You can see from the common hepatic artery, right gastric artery, both are anastomosing. See from the common hepatic artery, there is an artery which is passing, gastroduodenal artery passing posterior to the first part of the duodenum. It gives out right gastroepiploic artery here, and the splenic artery will give out the left gastroepiploic artery. Both of them are anastomose with each other, and these are the short gastric branches to the fundus of the stomach. So if you write these 5 arteries, you will get 5 marks. Venous supply, common, usually they will not ask, but 10 marks question you have to quote the answer here. Right and left gastric veins, right and gastroepiploic veins, and left gastroepiploic vein, drain to splenic vein, and short gastric vein, same like that of artery. So this is the vein, venous drainage. Okay. Ultimately, it will be drained into, see the splenic vein, ultimately drained into portal vein. This is a portal vein. Okay. It will not drain into inferior vena cava, but it will drain into portal vein. From there, it enters the stomach, and 80% of the blood supply of the liver is from the portal vein. So, portal vein drain the venous blood from the stomach, from right gastric, left gastric, right gastroepiploic, from all these into the splenic vein, from there into the portal vein, from there into the liver. Next, lymphatic drainage. Upper part of left 1/3 pancreatosplenic lymph nodes. You see here, upper part, okay, left side 1/3 part pancreatosplenic here. Upper left 1/3. Right 2/3 part gastric nodes. Okay, then right 1/3 part, okay, right gastroepiploic, and then pyloric part in different direction, pyloric, hepatic, left gastric, finally to the celiac. So whatever the lymph nodes are there, here left gastric lymph nodes, pancreatosplenic lymph nodes, right gastroepiploic lymph nodes, subpyloric group of lymph nodes, okay, hepatic group of lymph nodes. Ultimately, all this you can see the arrow here. Ultimately, they all will drain into the celiac group of lymph nodes, which drain into by the lymphatics into cisterna chyli. This is about the lymphatic drainage of the stomach. Now supply both sympathetic and parasympathetic. Sympathetic derived from thoracic T7 to T10 segments of the spinal cord, which passes down through the greater splanchnic nerve and supply. These are vasomotor constriction and dilatation of the blood vessels. Vasomotor constriction. There is no dilatation. No, it is an only help in vasoconstriction of the stomach, blood vessels. Motor to the pyloric sphincter, but inhibitory to the gastric musculature. Okay. Pathway for pain sensation is also carried by the sympathetic. So you can see the difference between the sympathetic and parasympathetic. You can see the vagus nerve here, which is parasympathetic supplying to the stomach. The vagus nerve is stimulatory for constriction of muscles in the wall of the stomach, but inhibitory to the sphincter, cardiac, the pyloric sphincter. But at the same time, you can see here for the stomach, here you can see this is the celiac ganglia. So from T5, T6, T7, T8 and T9, these nerves will pass, preganglionic fibers will pass into the cilia ganglia, postganglionic synapse there and passes and supply to the esophagus and the stomach, also to the small intestine. So these are the postgang sympathetic nerve fibers which are passing. So this is the sympathetic nerve. Sympathetic is the motor to the sphincter, but inhibitory to the musculature of stomach. But vagus nerve, which is parasympathetic, is motor to the muscle of the stomach, but inhibitory to the sphincter. So inhibitory means which helps in stoppage of constriction of sphincter, but sympathetic helps in constriction of the sphincter, so that it paves way for 2 to 3 hours for the food to mix with the enzymatic secretions given out by the zymogenic cells in the wall of the stomach. So the same thing, I'm not telling again. Okay. Interior of the stomach, layers of the stomach from inside to outside, interior of the stomach. It is one subheading, mucosa, submucosa, muscular coat and serous coat. You can see mucus coat, here muscular, this is the lumen of the stomach, mucus coat, submucous coat, muscular. Muscular means there are three types of muscles. The outer longitudinal, intermediate, oblique, and deep circular muscle coat is there. Outside of that is the serous coat. Serous coat is formed by the peritoneum which covers it. See the mucus coat? There are two MCQ questions here. Mucous membrane is thrown into irregular folds called gastric rugae. You can see here the irregular folds of mucous membrane. In lesser curvature, longitudinal folds of mucous membrane. You can see along the lesser curvature, longitudinal folds. It is called as gastric canal. Here it is gastric rugae. Mucosal layer, a small aperture, small aperture. When you see through the lens, there are small openings we can see on the surface of the mucosa, and it is called a gastric pit. Through the gastric pit, gastric glandular secretion will be given out into the lumen for its action with the bolus of the food which enters into the cavity of the stomach as we ingest the food. So muscle coat is made up of three layers, outer longitudinal, middle circular, inner oblique. Submucosa is connective tissue, arterioles, nerve plexus. Serous coat, peritoneal covering. You can see the four layers here. You can see the gastric rugae, mucosal layer. Okay, the three layers of the muscle coat you can see. Function, it's a reservoir of food, mixes the food, helps in peristaltic movement, softens and mixes the food with gastric juice. Secretions of the gland help in digestion of food. Glands produce HCl which destroys organisms present in the food and water. Mucus secretion protect mucosal layer and its corrosive action of HCl. Absorption of alcohol, water and salt produces intrinsic factor of Castle. Help in absorption of vitamin B12. Again MCQ question. Clinical anatomy, gastric pain. Okay, because of peptic ulcer. Gastric ulcers, you can see along the lesser curvature because of the most dependent part. Okay, because of corrosive action of the HCl. Gastric carcinoma, cancer of stomach, CA cancer. It is malignant cancer because of smoking, drinking, diet, and highly processed of salty food. Many times it is hereditary in nature also. Irregular multiplication of cells take place. Ulcer may convert itself into carcinoma. Pyloric obstruction, you can see the constriction here. Okay, pyloric obstruction. Congenital or acquired, causes visible peristalsis in epigastrium and vomiting. After the meal, directly vomiting will be there. It will not be digested. Hyposthenic and hypersthenic stomach. Asthenic means what? Sensation is lost. More prone to gastric ulcer and more prone to hyperasthenic means more prone to duodenal ulcer. So you can see the difference there. How the sthenic will be there, hypersthenic will be there, and hyposthenic will be there related to the stomach. They see the shape of the stomach also. Hyper, where it is horizontally placed, stomach is horizontally placed, hyposthenic J shaped, and it is constricted, and sthenic it is normal. Small intestine, anatomy of small intestine. Longest part of GIT extends from pylori curve stomach to the ileocecal fold. 6 to 7 meters long with a narrowing diameter from beginning to end. So MCQ question, they may ask length of the small intestine. They will give 6, 7 they may give. You write 6, that is correct. Actually, according to Chaurasia, 6 meters length. In other textbook, it is given 6 to 7 meters. You write 6, if there is no option of 7, you can go for 6. If there is no option of 6, you can go for 7. Okay. Longest part of GIT, 3 parts: duodenum, jejunum, and ileum. Color indicate, you can see duodenum, jejunum, ileum. Blue color is the jejunum, red color is the ileum. Okay. Duodenum is the most fixed in the convex part. It is color has not been given here. The duodenum, DJ junction, duodeno-jejunal junction. On either side, it is covered by the transverse colon. Transverse colon here it is cut. Okay, descending colon and ascending colon. You can see it's a parts of large intestine. Now going on to the duodenum, C-shaped, most curved, most shortest, and the most fixed part of the small intestine. After the stomach, it will be the duodenum. Starts from the 1.2 centimeters to the right of the median plane. Okay, at the gastroduodenal junction, 20 to 25 centimeters in length. 4 parts join stomach to the jejunum. Shortest, widest, mixed, fixed part of the small intestine. Important because bile duct and pancreatic duct open into it. It is important, you see. This may be asked in second part of the duodenum. That's the importance of second part of the duodenum. They may ask for 5 marks only second part of the duodenum. It curves around the head of the pancreas. First part 5 centimeters long at the level of L1. First part begins at the pylorus. Relations of the first part. Okay. Visceral relations. Anterior quadrate lobe of the liver and gallbladder. Posterior lesser sac. Gastroduodenal artery, bile duct, portal vein, and inferior vena cava. Superior epiploic foramen will be there, inferior head and neck of the pancreas. So it has got even peritoneal relations. The starting half of first part of the duodenum is actually mobile, as the lesser omentum and greater omentum will continue. Rest of the part is only related anteriorly. It is retroperitoneal. Okay. So it is a simplified diagram of the first part of the duodenum. So the complete duodenum you can see here. First part, second part, third part, fourth part. First part, superior part, descending or vertical part, transverse part, horizontal part. Fourth is the ascending part. Okay. So first part is the 2 inches. So the second part is 3. Third part is 4 inches. Fourth part is 1 inch. Total is 25 centimeters or 12 fingers in size. It is because of it is called as duodecodactylus. Extend from L1, L2, L3 vertebrae. Okay. And here you can see the common hepatic artery. Within the C-shaped concavity, you can see the pancreas passing. And you can see the gastroduodenal artery dividing into 2 arteries here. Superior pancreatic artery and then right gastroepiploic artery. And here in the junction between the uncinate process of pancreas and the pancreas, you can see the abdominal aorta is giving out a branch called as the superior mesenteric artery. From there, inferior pancreatic artery emerges. It anastomoses with the superior at the junction between the upper half and lower half of second part of the duodenum. So that's what it has been given here. Second part of the duodenum, about 8 centimeters, 78 in front of hilus of right kidney at the level of L2 and L3, about halfway down in the medial border, bile duct and pancreatic duct opens. So second part is important. Why is the bile duct joins with the pancreatic duct, it forms a ampulla called as ampulla of Vater, a hepatopancreatic ampulla. It opens out into the second part of the duodenum at the summit of major duodenal papilla, which is lies at the level of 8 to 10 centimeters distal to the pyloric orifice of the stomach. That's what you have to write in the second part of the duodenum. The examiners or the evaluators expect that answers from you. Relations of the second part: anterior right lobe of the liver, transverse colon, small intestine. Posterior hilus of the right kidney, ureter, right psoas major. Laterally, right colic flexor, medially head of the pancreas, bile duct, and the pancreatic duct. Opening of major and minor pancreatic duct, papilla, junction of foregut and the midgut. This figure you have to draw when they are going to ask the second part of the duodenum. You can see the major duodenal papillae, okay, bile duct and the major pancreatic duct join together and opens out into this. The accessory pancreatic duct opens out slightly above and anterior to the this duct through the minor duodenal papillae. This is the interior of the duodenum showing the cardinal features of the small intestine in the form of folds of mucous membrane called as plicae circularis, or the it is also called as transverse folds of mucous membrane, which becomes permanent whenever it is distant with the food. They will not obliterate by distension. Here you can see the hepatopancreatic ampulla encircled by the smooth ring of muscle fiber called a sphincter of OD. Ampulla of Vater, ampulla, dilated part. It is this called a sphincter of OD. That bile duct terminal part is covered by the sphincter called a sphincter choledochus. Terminal part of pancreas is covered by the sphincter called a sphincter pancreaticus. Okay, so the signals will carried by the hormone called as cholecystokinin and pancreozymin, which signals that the person has ingested the food rich in fat. Then only this sphincters will relax and the bilious secretion, the pancreatic secretion is poured into the second part of the duodenum for the purpose of digestion of food which is rich in fat. Here you can see the relations. Okay. See the ascending colon, hepatic flexor of colon, gallbladder, pancreas, anterior abdominal wall, then posteriorly the inferior vena cava. You can see the superior part of duodenum, second part of the duodenum, third part of the duodenum, their relations, coils of jejunum, psoas major muscle, okay, right kidney, is the purple color thing is the right kidney. You can see the bile duct passing here, and this is the auditus to lesser sac, means appendage. This is called as epiploic foramen. Okay, superior relations of the first part of the duodenum. In here it is the C-shaped concavity, there will be pancreas. So from anterior to posterior, this is the view what you can see related to the superior part, horizontal part, and third part of the duodenum. Third part of the duodenum is the longest part, 4 inches in its length, about 10 centimeter. It begins with the inferior duodenal flexor on the right side, lower part of third lumbar vertebrae. Ends by joining the fourth part in front of abdominal aorta. Relations: anteriorly root of mesentery of small intestine, supramesenteric vessels. Posteriorly vertebra, right psoas muscle, right ureter, inferior vena cava, and abdominal aorta, as you can see through the figure. Superiorly, the head of the pancreas will be there above the third part of the duodenum as it passes horizontally, inferiorly the coils of the jejunum. And relation to the first and second and third part of the duodenum, you can see here completely. Okay, so you can see the horizontal transverse colon, coils of jejunum. You can see the root of mesentery, root of mesentery containing the supramesenteric artery and supramesenteric vein passing related to the anterior part of third part of the duodenum. So third part is sandwiched between aorta and inferior mesenteric artery. You can see the third part of the duodenum section taken. The superior mesenteric artery passing anteriorly and posteriorly the abdominal aorta passing. So it is sandwiched between the two structures here. Okay. And also inferior mesenteric duodenal stasis may occur, compression between the two vessels. If the in between the two vessels, if it is compressed, there will be duodenum will be compressed. The food cannot pass through the duodenum, and it is called as Wilkie's syndrome. So this is the post relations of the third part of the duodenum, first and second part of the duodenum, fourth part of the duodenum also you can see. See, you can see the blue color inferior vena cava passing posterior to the third part, aorta slightly to the right of it, and you can see the gonadal vessels, right gonadal vessel, left gonadal vessel passing posterior. You can also see the ureter, relations of the ureter and the psoas major muscle passing posteriorly. And you can also see here the renal vessels passing to the right and left, right renal and left renal to reach the hilus of the kidney. So this is what supramesenteric artery passing anterior, but the gonadal artery is passing posterior to it. Fourth part of the duodenum, about 2.5 centimeters, run long upwards or immediately to the left of the aorta, up to the upper border of second lumbar vertebrae, where it turns forward continuously with the jejunum and forms the duodenojejunal flexor. So it occurs at the level of lumbar 2 vertebrae on the left side. So length of the fourth part is 2.5 centimeters or 1 inch in its length. Relations anteriorly transverse colon, transverse mesocolon, lesser sac and stomach. Posteriorly left sympathetic chain, left renal artery, left gonadal artery, inferior mesenteric artery. To the right, the root of mesentery, to the left, left kidney and the left ureter. Superiorly, the body of pancreas. Mucous membrane, thick in the first part, smooth remainder thrown into many circular folds called plicae circularis. Second part, medial wall is pierced by the bile duct and main pancreatic duct and major duodenal papilla. So this is related with the mucosal coat and its relation with the as it is extended into the main pancreatic duct and the bile duct, and also related with the major duodenal papilla. Blood supply partly derived from the foregut. I told you celiac trunk will give out the common hepatic. Common hepatic will give out the gastroduodenal. From gastroduodenal, superior mesenteric, superior pancreatic artery emerges. So superior mesenteric artery supplies into the midgut part. Celiac artery supplies into the foregut part. Upper half from superior pancreaticoduodenal, lower half by inferior pancreaticoduodenal artery, which is a branch of superior mesenteric artery. So blood supply of duodenum will maybe the question they may ask. It is also a must to know question. Veins, the superior pancreaticoduodenal vein drain into portal vein. The inferior vein joins the superior mesenteric vein. First part by three arteries, supraduodenal branch of gastroduodenal or right gastric or hepatic artery. Infraduodenal branch of right gastroepiploic artery, retroduodenal by gastroduodenal artery. These are three arteries for first part. Second part, not needed much. Okay. Then common, if you know the artery, that is enough. Venous drainage, reciprocal to the arteries itself, lymphatic drainage, pancreaticoduodenal and pyloric group. From here, lymph flows to the celiac nodes. Nerve supply of duodenum, sympathetic from celiac and supramesenteric. Segmental innervation T6 to T8, parasympathetic from both vagus. Pattern relations in relation to duodenum. So it is a retroduodenal. Only the first part, starting part of duodenum and in ending part of duodenum is suspended by the fold of peritoneum. Rest of all other part is mobile, retroduodenal, means it is fixed. But other relations are there in the form of recesses. You can see duodenojejunal recess. This may be asked sometimes for the 5 marks question. Peritoneal recesses in relation to duodenum. Then you have to draw this figure. That's enough. Draw the figure, name the parts. Duodenojejunal recess, superior duodenal recess, inferior duodenal recess. You can see the paraduodenal recess, inferior duodenal recess, superior and inferior. This is duodenojejunal recess. This is inferior mesenteric vein will be passing. So it is the inferior mesenteric. This is the recess, paraduodenal recess. And there is one more called as in here, one more retroduodenal, posterior to the duodenum, retroduodenal. And one more related to the supramesenteric artery. Okay, it is the mesenteric recess. Okay, this is the mesenteric recess, retroduodenal recess, infraduodenal recess. This is also infraduodenal, but it is side. So it is a paraduodenal recess, but this is the superior duodenal recess. Okay, and this is the duodenojejunal recess. As it passes, the fold of peritoneum covers the last part, terminal part of duodenum and passes. It extends the peritoneum, part of peritoneal sac extend upwards posteriorly, and that is called a duodenojejunal recess. These are all nothing but the extension of peritoneal membrane as it forms a sac-like structure. Okay, so that is called as recesses. Next, going on to jejunum and ileum. Before going to jejunum and ileum, I want to give you some cardinal features of small intestine. This is a MCQ question here. Cardinal features of small intestine is it is made up of circular folds of mucous membrane called as plicae circularis or walls of Kerckring. Number one. Number two, it is made up of intestinal villi and microvilli, which gives a velvety appearance to the surface of mucosa. There will be about 10 to 40 intestinal villi in per square millimeter. So these villi are about 1 to 2 mm in long, and they will give a leafy appearance in that proximal jejunum and duodenum. And as it passes to the distal part, it becomes sparse. Means they will reduce in size, and they will become, they are not so much condensed. Means there won't be any 40 intestinal villi in 1 square millimeter. Okay, so they will reduce in the number also. So the proximal two-thirds of the jejunum, proximal part of the jejunum, and in the duodenum, there you can see numerous this kind of intestinal villi. They're compactly arranged. Even the circular folds of mucous membrane are also compactly arranged, and they're thrown into folds which are compactly arranged. So this is the area where the digestion takes place. So it is enzymatic secretion of bilious secretion in the pancreatic secretion is poured. Intestinal secretion is also given, and it is admixed and it is segregated. The food is converted from complex to simpler substances. Jejunum and ileum are highly coiled and mobile part of small intestine. It is about 6 meters in length. First part, 2/5 is jejunum, rest to 3/5 is ileum. Coils of intestine are in the infracolic part of gastric sac. Greater momentum normally separates it from anterior abdominal wall. Because of highly coiled nature, it often herniates. Okay. So jejunum and ileum are mobile part. Only this much you remember. They are both are mobile part of small intestine when compared to duodenum. Duodenum is fixed and retroperitoneal. Okay, this constitutes about 6 meters in length. First 2/5 is jejunum, 3/5 is ileum. Okay, so here related to the position of jejunum, jejunum occupies the upper left intestinal area. Ileum, as the liver will be coming there, yeah, in the upper hypochondric region. The ileum occupies the lower right intestinal area. This is the anatomical difference between the position of jejunum and ileum. Okay, so jejunum will always be reddish in color. That means highly vascular because of the digestion function. So abundance of vascular supply is there for jejunum. So it is pinkish in color. Ileum, it will be light pale in color because vasculature reduces. Almost the food is converted, and the fecal matter, which is not devoid of water, has entered into the ileum. So the vascularity reduces there. So the jejunum begins at the DJ junction to the left of the midline and ends at the ileocecal junction. So ileocecal junction. Okay, from DJ junction to ileocecal junction. That is the length of the mobile part of small intestine, ileum and jejunum. So it is suspended by the fold of peritoneum called as mesentery. Okay, and it attaches it into the posterior abdominal wall, and that attachment extend related to the posterior abdominal as visceral peritoneum. So that part where it is extending from DJ junction to ileocecal junction at the right sacroiliac joint, that is called as root of mesentery. It is about 15 centimeters long, and it has got from the root of mesentery to the intestinal margin, it is 6 meters long. So from the left side, DJ junction will be at the level of L2 vertebrae, and on the right side, the say ileocecal junction will be at the level of right sacroiliac joint. So what is mesentery? It crosses from left to right, above, down. Third part of the duodenum, abdominal aorta. You see, these are the structures which lie in the posterior to the mesentery, and it will extend. The vessels will pass behind the mesentery. Inferior vena cava, abdominal aorta, right gonadal vessels, right ureter. These are the structures which lie and crosses from left to right, from above downwards. Content of mesentery. What is the content? Coils of jejunum and ileum, ileal branches of superior mesenteric vessels and ileocolic vessels, lymph nodes, nerve plexus, extraperitoneal connective tissue. So here you can see this is the figure of jejunum. You can see the vasa recta, the vessels, jejunal vessels passing from the arcade. These are the arterial arcades, what you can see. These are the windows. So windows are larger. Okay. In the windows are present in the jejunum, windows are absent in the ileum. Vasa recta is longer. Okay. Vasa recta is shorter. So here 1 to 2 arterial arcades, 1, 2, 3, 1 to 2 to 3 arterial arcades are present before it gives out vasa recta, which pierces the muscular coat of jejunum. But in the ileum, what happens? The arterial arcades are about 3 to 6, and as it reaches the terminal part of margin of intestine, the vasa recta is shorter and numerous, and the windows are usually absent, and there will be abundance of fat filled in the region of this window between the vasa recta. You can see this is the fold of mesentery, the root of mesentery. Fold from here to here, it is 6 inches in length. It is about 15 centimeters or 6 inches length, root of mesentery. And this is the jejunum, what you can see here. This is the vasa recta, what you can see. And the shining membrane, shining here is due to this fold of peritoneum. This is called as visceral for mesentery, covers the intestine, and it forms the serous coat or visceral peritoneum. Okay, it has been pulled upwards and it has been visualized. So the difference between jejunum and ileum is a 5 marks question. Okay, I have already told you jejunum. Okay, diameter and thickness of the wall is greater. Here it is thin and small. Arterial arcades are less. Vasa recta are shorter. Here vasa recta is long. Windows are transparent in mesentery because of the absence of fat. Here, because of the tightly packed with the fat, it is opaque. Windows usually will be very, very small, and if at all it is present, it is filled with fat. Plicae circularis mucosal fold, smooth mucosa, Peyer's patches in the antimesenteric margin present. Here, Peyer patches is absent in jejunum, but if it is present, it is circular. Here it is antimesenteric border, it is long, cylindrical, present in the antimesenteric border. Okay, mucosa will be smooth. Mucous plicae circularis forms the mucosal folds here. But here it is lesser. Plicae circularis is present, but it is sparse. And distance is more between one fold to another fold. Here it is compactly arranged. See the difference here? These are the folds of mucous membrane, compactly arranged plicae circularis. They will not get obliterated by distension. They will become much more prominent, made up of villi and intestinal microvilli, which increase the surface area of small intestine by 8 times. making it functionally very active for the digestion and absorption of the food. These are the Peyer's patches longitudinally arranged. See here the folds of mucous membrane, plicae circularis. The folds are very few and there is a distance is very large between one fold to another fold. These are the solitary lymphatic follicles which are continuously seen in the jejunum and ileum, even in the large intestine. This will be the intestinal villi, histological structure made up of columnar epithelium derived out of endoderm and small aperture. You can see it extends deep to the submucosa. This is called as the crypts of Lieberkühn. The crypts of Lieberkühn is the region where the cells are secretory in function and give out into the lumen of the lumen of the intestine. So whatever every 4 days there will be this line, the cells are regenerated. It passes like this, and it will be cast off. Every 4 days there will be casting off of this epithelial lining, and the new cells are lining the intestine. This is the plicae circularis, made up of velvety-like finger-like projection called as intestinal villi, and each villi is made up of the striated border here. The cells are made up of the ciliary projection called as microvilli. Arterial supply jejunum and ileal branches from left side of superior mesenteric artery enter the mesentery, except terminal part of ileum by ileocolic branch derived out of superior mesenteric artery. Venous drainage follows arteries and empty into superior mesenteric vein. From there, it joins the splenic vein and enter into the liver. It will not drain directly into the inferior vena cava, mind it. Lymphatic drainage, more important, carry product of fat digestion to the thoracic duct. See, each villi is made up of central green color structure called as lacteal. Each internal villi is made up of midline lacteal, one single solitary. This will carry the food which is rich in fat is digested and is carried into this lymphatic channel. So lymphatic channel join together to form the lymphatic, which drain the lymph into the cisterna chyli, from there into the thoracic duct, from there into the junction between the left subclavian vein and the left internal jugular vein. So it bypasses the liver. This will not enter into the liver itself. Now supply parasympathetic from vagus through superior mesenteric plexus, sympathetic through lesser splanchnic plexus, T10 to T11 segment. Pain sensation is carried by sympathetic T10 to T11 segment. Pain from jejunum and ileum is referred to the umbilical region based on the segmental innervations of the spinal nerves. So here you can see the portal vein, splenic vein, superior mesenteric vein, jejunal branches, jejunal tributaries, ileal tributaries, ileocolic artery, okay, and the right colic artery, mid-colic artery, okay, all this joined together by ascending branch and descending, ascending and descending, ascending and descending, join with one another. Ultimately, superior mesenteric artery join the right colic artery, ileocolic artery, and gives out the branch for appendicular artery. So here it is the venous drainage. They anastomose with one another. This splenic vein carry venous blood. From the hindgut, it is carried by the inferior mesenteric vein, join the splenic vein to form the portal vein. So superior mesenteric vein join with splenic vein to form portal vein. Inferior mesenteric vein join the splenic vein. So here this inferior mesenteric vein drain the venous blood from the suprarectal vein, sigmoidal veins, left gastric vein, and also left colic vein. Okay, and all this again drain the venous blood from the ascending veins and the descending veins. They all join together to form the marginal vein. So the blood supply of large intestine is from the marginal vein. Now going on to the peritoneum. Peritoneum is a thin serous membrane that lines the wall of the abdominal and pelvic cavities and covers the organ within these cavities. Peritoneum is a thin serous membrane. Parietal peritoneum made up of two types of peritoneum. Parietal peritoneum, same peritoneum only. When it lines the abdominal wall, it's called as parietal. The same peritoneum you see the cursor where I am passing parietal peritoneum, reflect over the visceral organ, it's called as visceral peritoneum. So you can see the complete liver is lined by the peritoneum called as visceral peritoneum. Again reforms fold here. So here also you can see parietal peritoneum lining the posterior abdominal wall reflect. So this is the falciform ligament. Then it lines the liver posteriorly. Then again forms the fold here. So posterior fold, anterior fold together forms lesser omentum. This is the stomach. Lesser omentum. Again covers the posterior part of stomach. Posterior layer as visceral peritoneum here. Visceral peritoneum covering the stomach here. And passes as first layer, second layer of peritoneum. Again folds to form third layer. Second layer forms third layer. First layer forms fourth layer. Okay. And this is called as greater omentum. Then third layer will pass over the transverse colon and completes the posterior layer of parietal peritoneum. So these are the retroperitoneal structures in the form of duodenum and the pancreas. So this is the opening called as opening foramen, epiploic foramen, through which the greater sac of this is the greater sac. This dark blue color is the greater sac. Is communicating through the epiploic foramen into the sac which is out posterior to the stomach. Posterior is the greater omentum called a lesser sac of peritoneum. And you can see the fold of peritoneum passing like this. This is the mesentery and its extension to the 6 meters length of the small intestine. Then you can see it is passing over the rectum, passing over reflected or the uterus, fundus of uterus, anterior wall of uterus, superior surface of bladder, then again continue as parietal peritoneum. So these structures are rectum, uterus, urinary bladder or retroperitoneal structures, subperitoneal structures also you can call it as. Okay, this is the posterior abdominal wall, attachment of peritoneum, separating it from the aorta, inferior vena cava, kidney, pancreas, retroperitoneal part of the duodenum, ureter. All these are retroperitoneal structures, and posterior to it is the vertebral column, bodies of vertebrae, what you can see. This is in short I am telling you. So parietal peritoneum lies the wall of abdominal and pelvic cavity. Visceral peritoneum covers the organ. What is peritoneal cavity? It's a potential space between parietal and visceral layer of peritoneum. In the male, it is a closed sac, but in female, there is a communication with exterior through the uterine tubes, uterus, and vagina. It got stuck. Stop. Hello? 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 Deepshika? Hello? Hello, can you hear me? They have stopped. Maybe they have stopped. But it's live. It's not going. Maybe they have stopped.
Hello. Ma'am, am I audible?
You are audible, madam. But it stopped. Slides, I could not go to next slide. Have you stopped?
It's changing, ma'am. The slides are changing. No, ma'am, the slides are changing. It is under your control only.
No. Mute. Sorry, Master.
ಇಲ್ಲ ಮಾತಾಡು ಪರವಾಗಿಲ್ಲ.
Maybe there is a limit, ma'am. 1 hour crossed, no. Let us. Limit is 200 slides. It is crossed 200. Shall I continue in the next session?
Yeah.
Shall I continue in the
But
next
there's
session?
nothing like that, ma'am. You can
No, there is a limit of 200.
you try
It
resharing the presentation, ma'am, once. Can you reshare, ma'am?
reshare, reshare, reshare. Then it will open. Okay. How many slides more? I will delete. Reduced. Can you see the slide? Wait. Can't. Hello? 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 What you will do?
Can
Teach
you
us.
change the slide, ma'am?
Yeah. Now? Now can you? Now is it okay? Can you see the screen? Hello?
It's still in the same slide, ma'am. Peritoneal cavity.
No? No? It's not changing, huh?
It is not changing to the next slide, ma'am. Previous one it is coming.
But here it is coming.
I think the presentation has ended, ma'am.
Yeah. So I can I take this session in the next tomorrow or so? Remaining part? Session is